surgical treatment of degenerative joint disease. Osteoarthritis is the commonest degenerative joint disease. It occurs primarily in elderly persons. It's characterized by erosion of the articular cartilage, hypertrophy of bone at the margins, which is called the osteophytes, subchondral sclerosis, and cyst formation, together with a range of biomechanical and morphological alteration of the synovial membrane and the joint capsule. The pathological changes in late stage of osteoarthritis, including softening, ulceration, and focal disintegration of the articular cartilage, and synovial inflammation also can occur. Despite the prevalence of the osteoarthritis, the precise etiology of osteoarthritis remain beyond our understanding. The articular cartilage is the target tissue for the cardinal symptom of osteoarthritis is pain, stiffness, and deformity. And the objective of our treatment is directed to alleviate pain, restore mobility, and to correct the deformity. As any other disease, we have pharmacological and non-pharmacological method of treatment which can alleviate pain and stiffness, but never to correct deformity, or we have a surgical method of treatment to alleviate pain, improve stiffness, and correct the deformity. The non-pharmacological mode of treatment is directed to modification of risk factor, physical therapy, and muscle strengthening exercise. All risk factors can be corrected for osteoarthritis, except the age and gender. Obesity, occupation, crystal synovitis, prior injury with proper treatment, sports injury, and muscle weakness. All of this can be corrected to guard against the osteoarthritis. The pharmacological method of treatment, including non-steroidal anti-inflammatory drugs, muscle relaxant, painkiller, and disease-modifying drugs. Also, local injection, including steroid injection, hyaluronic acid injection, and the platelet-rich plasma injection are used in treatment of osteoarthritis. Currently, the American Academy of Orthopedic Surgeons in 2015 was unable to recommend for or against the use of intra-articular corticosteroid growth factor, and platelet-rich plasma was inconclusive. They cannot recommend using of hyaluronic acid, which is strong evidence-based medicine. They conclude that corticosteroid injection may be considered insufficient evidence to recommend for or against the use of intra-articular hyaluronic acid. However, it may be considered for patients with inadequate response to pharmacological and non-pharmacological therapies. The surgical treatment of osteoarthritis is indicated in category 3 and 4 according to the function classification system in those patients with moderate osteoarthritis with other health problem, or in category 4 with severe osteoarthritis. The method of surgical treatment used in treatment of osteoarthritis either arthroscopic debridement, corrective osteotomy, arthroplasty, or arthrodesis. Arthrodesis are now considered to be obsolete if used in the big joint. It's still a way of treatment to arthrodesis, the cervical or lumbosacral spine, in treatment of spondylosis or some problem related to the spondylosis. Arthroplasty, there is no joint in the body is not being replaced nowadays. Hip, knee, shoulder, elbow, ankle, interphalangeal joints, the rest, and now they are replacing the intervertebral disc, considered as a joint as well. We are highlighting the treatment of the knee and hip osteoarthritis as example for the treatment of degenerative disease, considering them the commonest involved joint you will face in your outpatient. As regards the knee, arthroscopic debridement. The arthroscopy is indicated in severe symptomatic osteoarthritis with failure of non-surgical method of treatment, in presence of either loose body or mechanical symptom, locking, giving way, or catching. There is no place for arthroscopy if there is nothing to do. The philosophy of just wash out the knee is not considered anymore. The tibial osteotomy, being its open wedge or a closing wedge, are used to correct the alignment of the knee to help to decrease the progress of the osteoarthritis. It's not a curative for osteoarthritis, but it decreases the progress of osteoarthritis. If we look to the closing wedge, you are excising in varus osteoarthritis the presence of medial compartment osteoarthritis. You are excising a wedge. In opening wedge, you are opening a wedge. In this diagram, if you look, there is narrowing of the medial compartment of the knee in the first part of the figure. The distal axis of the femur and the proximal axis of the tibia are not parallel to each other, so you are doing a closing wedge osteotomy based laterally to correct the axis of the proximal tibia. After closing this wedge, the proximal tibial axis and the distal femoral axis are parallel together. The high tibial valgus osteotomy is indicated in patients less than 60 years of age and a unicompartmental osteoarthritis. We are considering the knee of three compartments: the medial compartment, lateral compartment, and the patellofemoral compartment. So it's indicated only in a unicompartmental knee osteoarthritis. Varus deformity or valgus deformity should not be more than 15 degrees, and the range of motion should around 90 or more degree of flexion extension. The flexion contracture should less than 15 degrees, and the ability to motivate and follow the rehabilitation program. These parameters also are the criteria for selection to do a unicompartmental knee replacement. The problem with the high tibial osteotomy or collective osteotomy of the knee is it gives a short-term improvement, with the patient selection is crucial, and it adds difficulty for the future total knee. If we are considering the knee replacement or the joint replacement in treating osteoarthritis of the knee, the main indication for total knee arthroplasty is for relief of pain, correct the deformity, and restoring the range of motion associated with arthritis of the knee in patients with failed non-operative treatment. Joint replacement is considered one of the top 3 innovations in medicine in the 20th century, together with the IVF and the coronary angiography. We have two kinds of replacement. The unicompartmental knee replacement is considered to replace the high tibial osteotomy we mentioned before in replacing just one compartment in presence of unicompartmental knee osteoarthritis. Or a total knee replacement, which we are replacing the proximal tibial articular surface, the distal femoral articular surface, and with a polyethylene insert in between the two metal components to replace the menisci. A lot of options you have in doing a knee replacement, a total knee replacement. The fixation, is it a cemented one or a cementless one? The cemented total knee replacement is the gold standard since the start of the knee replacement. The cementless fixation is growing nowadays in the United States, and hopefully by 2050 it will be the gold standard for replacing the knee, with their excellent result from the short-term and mid-term studies. The difference between cemented and cementless is the cost. The cementless prosthesis is triple the cost of the cemented one. It's a surgeon preference. Sometimes some surgeons are preferring to do a cementless replacement if they are doing a knee replacement in patients less under the age of 50 years. And the results. The cemented has a long success track record compared to the cementless one. The other option you need to choose about the posterior cruciate ligament. Are you retaining the posterior cruciate ligament or you are sacrificing the posterior cruciate ligament? In presence of fixed flexion deformity more than 15 to 20 degrees, you might need to sacrifice the posterior cruciate ligament. If this flexion deformity is combined with a varus deformity or a valgus deformity more than 15 to 20 degrees, you should sacrifice the posterior cruciate ligament to allow to straighten up the knee in both sagittal and the coronal plane. The age. Most surgeons advocate to retain the posterior cruciate ligament under the age of 50 or 55 years because of their stabilizing factor in the knee, and also the proprioception are kept inside the knee. The polyethylene insert, we have two options, either a fixed or a mobile polyethylene one. The mobile polyethylene one are forgiving. The mobile polyethylene can compensate for a mal rotation of your component about 15 degrees. So it can be used according to the surgeon volume. In the start of the training program, you might need to use the rotating platform or the mobile polyethylene insert. And sometimes you should use the mobile polyethylene in patient presenting with a knee osteoarthritis with a rotational malalignment. This is a 53 years woman with repeated effusion, painful, stiff knee, failed conservative measure. She can't look after her home. She had a marked destruction in the ulceration of the articular cartilage with thickened brownish villus synovitis, which proved to be a pigmented villonodular synovitis. She had a cemented BCL sacrificing rotating platform total knee replacement. Another 87 years lady with a bilateral severe varus deformity, difficulty in routine daily activity. We can't have her standing one leg x-ray because she can't perform this. She had a bilateral knee replacement with a BCL retaining one with a fixed platform with almost a full range of motion of her both knees. So, to sum it up about the treatment of knee osteoarthritis, either arthroscopic debridement in presence of mechanical symptoms, in presence of catching degenerative tear of menisci are giving symptoms. We can use high tibial osteotomy, which is now being replaced by a unicompartmental knee arthroplasty and a unicompartmental knee replacement under the age of 60 with limited varus and flexion deformity less than 15 degrees with a fair range of motion. Or we are shifting to the gold standard of advanced osteoarthritis by doing a knee replacement. If we are speaking about the hip osteoarthritis, there is no place for arthroscopy in treating hip osteoarthritis. So we are left only with osteotomy, which mainly a prophylactic rule in treating osteoarthritis, or with arthroplasty, which is the gold standard in treating hip osteoarthritis. The osteotomies around the hip is either a femoral osteotomy, it's maybe a varus osteotomy or a valgus osteotomy. By a varus osteotomy, we are doing a femoral osteotomy to decrease the neck shaft angle. By a valgus osteotomy, we are doing an osteotomy to increase the neck shaft angle. The idea is to either to cover a healthy part of the femoral head, as in varus osteotomy, or to uncover unhealthy part of the femoral head as a valgus osteotomy. On the other side, you can do also a pelvic osteotomy to increase the coverage of the femoral head. The hypothesis of osteotomy is that it improves the hip function by increasing the contact area and congruency, improves the coverage of the head, moving a normal articular cartilage into weight-bearing zone, and restore the biomechanical advantage and decreasing the joint reactive forces, which they assume they stimulate the cartilage repair. If we look to this diagram with this arrow showing about an healthy part of the articular surface outside the acetabulum, in doing a varus osteotomy by cutting a wedge with a base medially and fixing with a plate, as we look in this diagram, are showing that the femoral head is more covered. The varus femoral osteotomy disadvantage is it potentially shortens the limb, weakens the abductors, giving a Trendelenburg gait, and potentially difficulty in stem insertion in the future arthroplasty. The valgus osteotomy is in contrary, you are excising a triangle with the base laterally to take this osteophyte pointed by this arrow from inside the acetabulum to be outside the acetabulum. The pelvic osteotomy, almost 65 types of pelvic osteotomy is described. The idea is to increase the coverage of the acetabulum. The most common one used in prophylactic or in treating the dysplasia, which is a precursor of osteoarthritis, is the Gans periacetabular osteotomy. By doing an osteotomy to the entire acetabulum, superior, medial, and inferior one, and rotating the acetabulum, as shown in this diagram, to cover the femoral head, and sometimes you need to augment with a varus osteotomy to increase the coverage, as shown in this X-ray. Again, if we are speaking about the total joint replacement, the indication of the hip replacement is for relief of pain, correction of deformity, and restoration of range of motion. We can't speak about joint replacement without mentioning these two guys. Simo Steelbrook in 1880, the first one on earth who describes the joint replacement, and introduced his patient in Berlin in 1880. And John Charlie, the godfather or the father of the modern hip replacement. The problem with the hip replacement usually is the longevity of the prosthesis. So John Charlie stated that he recommended not to use it with young active patients, except in patients with a built-in restraint as rheumatoid arthritis or polyarthropathy, with limited range of motion. With the improvement in the metallurgy and tribology of joint replacement, this limitation had been abolished. If we look to John Charlie articulation, metal and conventional polyethylene with amount of wear, volumetric wear 200 micron per year, and the bearing surface we have now with less than 1 micron volumetric wear per year. That's the difference. That's what shift total hip replacement to be able to do in teenagers. Again, you had a plenty of choice, whether a cemented or a cementless fixation. We mentioned in a knee replacement that the cemented fixation is the gold standard, but now in hip replacement, the cementless is the gold standard. You need to choose your cup pairing with a conventional polyethylene, which is not more in use now, highly cross-linked poly, ceramic, or a metal. You need to choose your head size, 28, 32, 36, ceramic or metal. The increase in the size of the head increase the stability and increase range of motion. If we look to this X-ray with old person's disease, had a cemented hip replacement. The idea of cemented hip replacement, you are using a polished stem inserted in a low viscosity bone cement into the medullary canal. With this pressurization, allow the interdigitation into the interstitial space of the cancellous bone. The problem with the cemented prosthesis is the cement disease or the osteolysis. If we look to this X-ray after a cemented prosthesis with the polyethylene wear initiating immune response with this amount of osteolysis, which require massive surgery by allografting and long stem prosthesis. That's why they shifted to use a cementless one. In a cementless fixation, we can use a metal on metal X large head, as this 22 years male with acetabular femoral impingement and osteoarthritis, or even we can use a much more better pairing surface, 36 ceramic on ceramic, delta ceramic, for a 26 bilateral avascular necrosis in a pharmacist. The term conservative hip arthroplasty or a minimal resection arthroplasty, that's a question why you are invading the medullary canal, just replacing the articular surface of the femoral head. This comes with this resurfacing arthroplasty. But the problem with this resurfacing arthroplasty is a fracture of the neck of the femur in some patients. That's why they shift to the short stem total hip replacement. Try to leave the majority of the medullary canal as version as before surgery that allow a better and easier revision in the future. The result of total hip replacement is a very satisfactory for both patient and surgeon with less than 2% complication. The improved manufacturer and the bearing surface add to the success of the procedure. The improved longevity, generally it's one of the most successful operations. But there is no surgery without complication. DVT and pulmonary embolism are higher after joint replacement. Infection, which is a nightmare of the surgeon and the patient. Loosening of the component. Periprosthetic fracture, whether in the acetabular or in the femoral side, and instability. The computer-assisted surgery are giving some hope in correcting some of the problem with the joint replacement. It managed the malalignment problem. It's a legal problem. It's more precise component orientation. The problem is the long time it takes and the increase the complication, general complication as DVT and pulmonary embolism and sometimes infection. The idea is you are using an instrument with infrared bulbs with camera behind the surgeon to allow to bring all lines in the computer in front of him. In this screen, the surgeon need to align the yellow line to the blue line. If your in orientation allow to superimpose the yellow and blue line, you are in the correct position. It takes time, it takes money. They shift to the handheld navigation for the total knee and total hip, which is something like smartphone attached to your instrument. And the much more advanced is the robotic surgery, but it's higher in cost and it's almost in the United States and Germany. To sum it up, arthroscopic debridement has a role in selected cases of knee osteoarthritis. Realignment osteotomy are still in use in unicompartmental knee osteoarthritis. Total knee and unicompartmental knee are now the gold standard for the treatment of advanced osteoarthritis of the knee. There is no place for arthroscopy in hip osteoarthritis. Osteotomies around the hip are a prophylactic one rather than a curative one. Hip arthroplasty is the gold standard for treatment of advanced hip osteoarthritis. Improves the material and the manufacturing technique had added to the success of the arthroplasty. The computer-assisted surgery is a noble way, but it had its limitations and drawbacks. Thank you.